Hi folks, this is Dr. Rob Sivas, the CarbAddictionDoc. And for those of you that know, for those of you that don't know, I'll reiterate, I am a medical doctor. I am licensed in 3 countries in the world and in 5 US states. I have both an MD degree and a PhD from the University of Toronto, but I'm also a board-certified adult general surgeon as well as a board-certified pediatric surgeon. That's my medical credentials, my medical background. Over the last 25 years or so, I've become increasingly interested, both personally and from a physician perspective, in what drives metabolic health, including diabetes, including obesity. And as a surgeon, I first encountered obesity in myself, topping out at close to 300 pounds, as well as in a lot of kids who I was operating on for other reasons. They had gallbladder disease, they had ovarian disease, they had uterine disease. They had diseases that children should not get. And while I could take out the gallbladder, I could take out a twisted polycystic ovary, I could deal with those things in children. What we really didn't have an answer to is, why the hell are these young kids getting these adult diseases? And why do even adults get these diseases? So over the last 25 years or so, I've more and more started focusing on an understanding of what is going on from a disease perspective, because clearly these diseases did not exist in the magnitude that we're seeing them right now in 2020, 21, 30, 40 years ago. Literally within my lifetime, these diseases did not exist unless being very, very trivial. And the magnitude of these diseases has gone through the roof. And what's interesting, even though I'm not a gynecologist, I do pediatric gynecology because that's what we do as pediatric surgeons. What I do want to do, forgive the COVID hair, what I do want to do is to read a letter I got the other day. There was a real contemplative wake-up call for me. And the email, I'm going to read it in its entirety. It says, "Bravo, Dr. Sivas. I just finished your obesity lecture on Nutrition Network and feel very validated. I am an OBGYN in California who treats abnormal uterine bleeding with LCHF, low carbohydrate, high fat lifestyle management, among other treatments. You understand this as a surgeon yourself. I also use medical management such as oral contraceptive pills and surgery, etc. However, LCHF, low carbohydrate, high fat diet is becoming my mainstay of treatment. I'm doing a lot of clinical research and observation, and in my literature reviews, I'm seeing more and more that the inflammatory factors that cause uterine fibroids and endometrial polyps are similar to the factors that cause atherosclerotic change in the vasculature. What we forgot as gynecologists is that the uterus is one big smooth muscle. And it behaves similarly as the endothelium of the peripheral vasculature. Just a little segue here is that all your blood vessels are basically endothelial cells and then a layer of smooth muscle in the arteries and sometimes in the larger veins, and then an outside fibrous layer. So all blood vessels have a huge, especially the arteries, have a huge smooth muscle component. And the uterus is just this big, bulky, smooth muscle, as she says. I am noticing that I have 2 types of patients with AUB, abnormal uterine bleeding. Overweight, normal weight with fibroids, endometrial polyps leading to heavy bleeding, and obese patients with normal-sized uteri who have heavy bleeding. So you've got skinnier people with these very disfigured uteruses that have abnormal bleeding, and then you have obese people with relatively normal uteruses that also have abnormal bleeding. Interesting. Are they related? Are they the same? Are they different? What's the difference? Your teaching on the obesogenic and diabesogenic disease physiologic pathways now validate and demonstrate why I see such a difference in disease pathology that seems the same. The thin, overweight patients have atherosclerotic disease pathways that lead to fibroids. The obese patients have chronic intracellular inflammation that leads to endometrial cancer in my patient population. Fascinating. Thank you so much for making this clear to me. Best regards. I'm not going to use her name, but there's the email, folks. And let's explore that a little bit, because it's such a fundamental mind blow, even to someone like myself. I knew of this but because it's not my specialty, I didn't do a deep dive into it. But actually it is my specialty. Not gynecology, of course, but understanding metabolic dysfunction. So here's what she's saying, and it's an interesting concept. When I was training as a medical student in the early 80s, late 70s, early 80s, it was rare as rocking horse manure, folks, to see women with fibroids, with endometrial disease, even uterine cancer was as rare as hen's teeth. And this wasn't that long ago. This is 40, 50 years ago. Very, very rare. Very rare. And certainly hysterectomies were very unusual operations for benign disease. Now, when I look at the surgical list, when I go into the operating room as a surgeon, I look at my gynecologic colleagues, they are just lists and lists and lists of gynecologic surgeries where they're ripping out uteruses. TAH, BSO, TAH, TAH. TAH is total abdominal hysterectomy, partial hysterectomy, cervical surgery. Ripping out uteruses left, right, and center for abnormal bleeding, for fibroids, and for cancer risk. Why have we seen this exponential escalation? This exponential escalation of uterine disease in women in their 40s and 50s. These are young women, often of childbearing age, and yet they're having their uteruses ripped out, well, surgically resected, robotically removed, for metabolic reasons. And what she says is absolutely correct. The two pathways that we see are related directly to the damaging effects of either hyperglycemia, high levels of blood sugar, or hyperinsulinemia and insulin resistance, high levels of insulin. And the two are slightly different. Hyperglycemia is associated with insulin resistance, and hyperinsulinemia is in and of itself its direct effect. What's the difference? Well, with hyperglycemia, you're eating a lot of carbohydrates, and there lies the root cause problem, folks. It's chronic excessive carbohydrate consumption and a lack of saturated fat in our diets. When you eat a ton of sugar, your body can respond in one of two ways. And this is the genetic, biological way your body responds. If you eat a lot of sugar, your blood sugar goes up very quickly, and the pancreas releases insulin to clear the sugar from the bloodstream. Problem is, then that sugar mostly gets distributed into your cells, and now you get intracellular hyperglycemia, high blood sugar levels inside of the cells, which is toxic to the cells. So the cells say, screw you, insulin, and they shut the front door and they change the lock. They change the receptors, they phosphorylate the receptors so that the receptors no longer respond to insulin and you can't get sugar into these cells. So your blood sugar goes up. And if your pancreas can produce a ton of insulin, now no matter how insulin resistant your cells are, your pancreas can produce more insulin, you can force that sugar into the cells. Okay? And in that way, particularly in the liver and the fat cells, we call that an obesogenic pathway, where the body can turn that into fat very readily. Those people become enormous. Their blood sugar isn't very high, a little bit high, but they do not develop profound diabetes. And the problem with those folks is that they then suffer the consequences of chronically elevated insulin levels. I'm going to come back to that in a second. On the other side, if you cannot produce a lot of insulin, now you're eating all the sugar, your blood sugar goes up. At first, you can force that sugar into the cells with insulin, but when the cells lock that front door, when they become insulin resistant, no, you can't produce more insulin. So you've got insulin resistance, but to a very small amount of insulin, and you get this massive increase of blood sugar. And obviously the focus of that has been diabetes, and the focus of that has been atherosclerotic heart disease, damage to the blood vessels themselves. But folks, the uterus, the female organs, while being this big lump of smooth muscle, remember that uterus, for a lot of people, has to contain a baby. It has massive growth changes. Plus, the uterus is feeding a lining. And that's what sheds once a month for most women with their periods. Little blood vessels. So the uterus not only is this big lump of smooth muscle, it is highly, highly, highly vascular. And just like the changes we see in every organ out there, where the blood vessels get affected by hyperglycemia and insulin resistance, exactly the same process is happening in the uterus. And then you get these nodules of regenerating muscles. So these muscles die off and grow, and they grow very abnormally. And if they grow inside the walls of the muscles, you get fibroids. But if they grow closer to the inside, you get polyps. And the polyps have a much bigger lining that can bleed excessively. So the dysfunction that we're seeing, these fibroids and these polyps in the uteri of women who can't get the sugar out of the bloodstream into their fat cells, so they may be slightly overweight or a little bit heavy, but not morbidly obese. Those women are getting these massive fibroids and endometrial polypoid disease directly because of their high carbohydrate, low fat diet. On the other side of the coin, we get the hyperinsulinemia patients. And when your insulin levels are continuously elevated, that starts to block. You've got high cholesterol production because insulin promotes cholesterol production. Insulin promotes continuous protein synthesis, and insulin blocks the pathway of cholesterol downstream through a series of enzymes to the end-stage hormones, which are estrogen, testosterone, progesterone, cortisol, catecholamines, and the conversion of T3 to T4, which is a phosphorylated kinase receptor. So all of these things are cross-reacting under conditions of hyperinsulinemia that is consistently up. Remember, normally insulin levels should fluctuate, never very high, but should fluctuate with meal times and then between meals. Well, if your insulin levels are always up, that causes disasters. And under those conditions, those women very often develop high levels of testosterone, low levels of estradiol, and they may or may not have high or low levels of progesterone. Those women become enormous, but they also develop polycystic ovarian disease. Their risk of diabetes is very, very low. And what does that polycystic ovarian disease do? It disrupts the cyclical hormonal flow from the ovaries. So the ovaries get multiple cysts on them. What do we call that? Polycystic ovarian syndrome. But they develop, because of the high testosterone, they develop an androgenic, male type look. They get hair on their bodies, their skin becomes thicker, their cycles become abnormal, and they get dysfunctional uterine bleeding. They also have infertility. So the outcome, fibroids, endometrial polyps, and polycystic ovarian disease, even though they occur in different types of women, the root cause is chronic excessive carbohydrate consumption and non-consumption of saturated fat. So if you flip their diet around, a lot of those issues can improve. Yes, you may need some help along the way with oral contraceptive pills to restore the cycling in certain women, maybe metformin to quell the sugar production of the liver because there's that disconnect. But ultimately, if you become insulin sensitive, you reduce that risk. And we haven't even begun to talk about uterine cancer, which is clearly an end-stage form of the same process. So think about this, folks. In the modern era, the more and more gynecologic disease that results in permanent removal of the uterus and often the ovaries, which is awful. I'm not even talking about the psychology of a woman having to undergo that surgery, not just from the hormonal disruption, But can you imagine being a woman of childbearing age, losing your uterus because of something that you did to yourself, unwittingly, unknowingly? Well, folks, if you've watched this video, now you know. Now you know. The best way is to prevent the disease by having your children early on, by having your teenagers, by having young women quit eating carbohydrates. Go keto, go low carb, high fat, even if you want to go carnivore if you choose to, but radically reduce your carbohydrate consumption, increase your fat consumption, and the earlier you do it, the better in terms of prevention. The earlier you do it, the better in terms of prevention. But even down the road, you can stabilize and potentially reverse these diseases. Wow, what an eye-opener from this doctor who saw some of my work and took that work from blood vessels and obesity and put it into her own perspective and just blew my mind when I realized, wow, here's somebody that gets it within her own specialty. What a beautiful thing, what a sad thing, and yet so reinforcing. Please, gynecologists, please, women of all ages, particularly mothers of young girls, figure this out early. It matters, folks. It matters. With the uterine cancers and cervical cancer, which the cancer not associated with HPV, with ovarian cancers going through the roof, look at the carbohydrate influence. And prevention is so much better, folks. just one little statement though. The commonest complication I have in my practice is unplanned pregnancy. 12% of my fertile females come out, oh, I've got polycystic ovarian syndrome, I've got gestational diabetes, I can't get pregnant, although the diabetics can. I can't get pregnant, I haven't had a period in a long time, I bleed like crazy, I'm on hormone. They go keto, and 6, 8, 12 months later, guess what? They're gaining weight. But I'm eating right, I'm not eating wrong, I'm not eating carb, I'm gaining weight. Folks, I have pregnancy tests in my office for exactly that reason. 12% of my fertile females, when they go keto, suddenly find out they're pregnant. And it's because they sat on a warm toilet seat. Oh, I didn't have sex. How? I'm 15 years old. How could I have had sex? You're pregnant. Maybe you sat on a warm toilet seat. Maybe there's something you haven't told us, but we have evidence. So if you're going to go keto and you don't want to have a baby and you're a fertile female, use some form of protection. Because I don't want you to add to my 12% of complications. But it's kind of a good problem to have. And from an infertility perspective, there are a number of infertility practices that refer patients to us because PCOS is the commonest cause of infertility. So there's no reason other than the high you get, the dysfunctional high you get, for eating carbohydrates. And for fertile females, for females who want to keep their uteruses, who want to be healthy and not have that dysfunctional uterine bleeding or the risk of, or reduce your risk of endometriosis, of endometrial cancer, folks, adopt a low-carb, high-fat lifestyle. It makes a massive difference. Thanks very much to this doctor. See you next time.